Hi, I'm Earl Silverman, Editor-in-Chief of the Journal of Rheumatology. I hope you're all doing well and healthy during the coronavirus pandemic. Today, I'm pleased to be speaking to Dr. Roberto Caricchio, who is Chief of the Division of Rheumatology at the Lewis Katz Medical School, Temple University, who with Dr. Gerald Criner, who's the Chair of Thoracic Medicine and Surgery at the same institution, are the authors of a research letter entitled Rheumatologists and Pulmonologists at Temple University Weather the COVID-19 Storm Together. This research letter is available via open access at the journal's website at jroom.org. Dr. Caricchio, I want to thank you and Dr. Criner for writing your research letter and for joining me and agreeing to discuss how Temple University Hospital has been dealing with the COVID-19 pandemic. So start with the questions. So to my knowledge, and correct me, the combined input of thoracic medicine and rheumatology to treat patients with COVID-19 is unique, at least certainly formalized. And you can please explain to me why Temple had decided on this approach.
Yes, so first of all, thank you for having me here. It's always nice to talk across the border. And we are in a way rare, I would say, unique. I'll take a unique, but we're not completely unique. In fact, in a recent survey by the American College of Rheumatology on this very topic found that, yes, a minority of rheumatology sections and divisions in the United States have actually collaborated fully with the lung institutes or centers to actually approach COVID-19 infection, which is obviously primarily a lung disease. Nevertheless, it is a systemic at some point with major organ involvements as well. And so why we were in the rheumatology section the lucky ones? Well, I'd say there are several factors that played in these events. So first of all, the entire Temple institution, the university, prepared itself to the pandemic. We were watching from Europe what was going on, the news that were coming, and then watching New York State, what the pandemic going there. So in that period, which was February, end of February, Temple prepared itself to the pandemic in a way by redeploying basically an entire structure of the complex. So one building at Temple University was transformed in an ICU structure. 8 floors of ICU to make up for the numbers that we were anticipating, which were roughly 300 a day. 250, 300 a day worth of patients needing of ICU care. And so that was happening at the end of February and the first 2 weeks of March. Meanwhile, I was actually recovering from abdominal surgery at the end of February, and I was on my family leave, medical leave, the first 2 weeks. I was watching, of course, learning about this condition, and of course, quickly noticed that the medications that they were at some point used in China and then later on in Italy were biologics that rheumatologists usually employ in a variety of conditions, including cytokine storms, which I have an interest in. And so in mid-February, I reached out to Jerry, Dr. Criner, mentioning him the fact that those medications were rheumatological and that we had a great expertise, of course, experience, and if we could be of help. He mailed me back that evening on the 15th saying, well, why don't you participate to our call? So meanwhile, they were having daily updates on how restructuring the Temple University to make front for the pandemic. And so at 4:30, I went on board. I prepared a presentation for them. There were roughly at that point up to 200 individuals on that daily meeting at 4:30. I prepared a presentation on the cytokine storms that occur under certain circumstances, such as HLH, MAS, and the CAR T cell cytokine storm as well, secondary to CAR T cell, and made the case to say, hey, this is what is is used in Italy and in Europe in general, but also some data from China. I think we should all together approach this disease, not always, of course, but under certain circumstances with those medications. And so it began.
That's great. Very good foresight. You really have to be prepared if you're going to do something well.
And we had, we had really 1 week after the 15th of March, because the week after, by the 21st, we were having 10 to 15 patients admitted a day.
Wow, that's impressive. Yes,
yeah. Unfortunately, because it was very taxing for everybody.
Sure. In the research letter, you mentioned that you've treated several hundred patients in the combined approach, and that 92%, I was impressed, of the hospitalized patients went home.
Yes. So yes, it was. We had at least 430 phone call with roughly again 200 patients, 200 individuals. And by the way, those 200 individuals were not by any stretch of imagination only part of the thoracic medicine surgery department. No. There were multiple teams. We were involved in the cytokine storm treatment, by which we helped. Recognizing it by having daily laboratory markers to be drawn on day 0, actually from the emergency room. So we helped in that regard too, but also the cardiology team was on board, the infectious disease was on board, the nephrology team was on board, being these patients highly, there is a higher percentage incidence of patients with chronic kidney disease or end-stage renal disease. So there were a variety of teams, neurology because of the neurological manifestations, and gastroenterology. So it was not just rheumatology; it was a very inclusive approach to the COVID-19, and so every day we were receiving 20 to 30, at some point 40 patients a day actually admitted for a couple of weeks. And what happened is that based on the protocol that we set up, and there was, yes, the lab work, but also a high resolution CT besides the nasal swab for the RT-PCR, the patient was diagnosed either at various stages, severity stages. So if the patient was just having some oxygen need and the ground glass opacity now classic, it would have stayed in the hospital for a few days, most likely, with the now classic combination, which is azithromycin and remdesivir. And in our case, we did give some low-dose steroids, as now everybody else is doing. And many of those patients, after a few days with really extensive respiratory support, would have gone home. But there were this fraction, which is roughly 20%, 25%, who went on in developing a much more systemic inflammatory response. And so the pulmonologists were aware of that, because we, with the presentations that we gave them, we basically trained them in recognizing that. And if that was the case, they would have consulted rheumatology, and we would have gone through the type of therapy that that patient would have been more suited for. And that amounted to roughly 300 patients, 250. Yeah.
Right. So you said that you now, you have your protocol, and I know certainly worldwide, and I'm sure throughout the US, Canada, and these big collaborations, are you now part of trials for the drugs? And you mentioned some of the drugs, and I'm sure the anti-cytokines. So
yes, so quite a few actually. So the patients that we were, the rheumatology was consulted, were those that, yes, certainly had these features of systemic inflammation, hyperimmune response, but also either did not fit the clinical trials that we were or are participating, or just they didn't want to have the placebo risk, which is understandable. So yes, now we participate in quite a few. So for the pulmonary team, they set up trials with not just remdesivir for the first wave of remdesivir trials, but also sarilumab, which is another anti-IL-6 receptor inhibitor. We are part of the tocilizumab trial, two of them, the gimsilumab, the anti-GM-CF trial, with the canakinumab, the anti-interleukin-1 beta trial, which just finished recruiting, as much as also for sarilumab, who has been finished the recruitment. And we are most likely get on board with the anakinra and which are trying to reproduce the phase 1 that they did in Italy. And most likely soon we'll be also part. Actually, no, we've been already selected for the baricitinib clinical trial. Of course, and we have a tremendous success in recruiting. It's like almost half of the population that was offered. I think we're looking into that, and there will be publications on that, because our population is by far minority. So we have roughly 80% of the population is minority, of which of this 80%, 65 is African American, and the rest is Hispanic. So I think the pandemic and really the lack of medications that we know for sure they work have pushed individuals to actually be more open to clinical trials, because it's either that, although we did offer the alternative, which was the same thing but outside of clinical trial, but nevertheless, I think the success was also that part, that the pandemic might change minds because of the availability of medications. We did use hydroxychloroquine, but only for 2 weeks. It took some time before starting the use. We couldn't really, we couldn't really agree if yes or not, and I was partially skeptical. Sorry, but we used only in very few patients.
So with the cytokine storm, the analogy, as you said, is MAS, HLH, whatever you want to call it, hyperactive immune system. And I think what you were saying, I think the key to it is what you're doing. It always struck me with these diseases that it seems like the people who do worse are always a day behind. So to test everybody to look for ferritin, the other markers that we know are associated with cytokine storm when they enter, I agree, is the way, and maybe that's why your patients are doing well. And that's just, you don't have to answer this question if you don't want to. What's your gut feeling about IL-1 versus IL-6 blockade if in a patient not entering a trial?
Well, actually, we are preparing our experience. We are writing as we speak, and as preliminary, because we have patients that we treated with tocilizumab and patients that with anti-IL-6 and patients that we treated with anti-IL-1 outside of clinical trials, and we are not seeing much of a difference. Now, it is a prospective work, obviously, and outside of a clinical trial, so we might have been biased with one toward the other, and we are analyzing the data as such. And by that I mean, so if you look back a month ago, 2 months ago, which seems, the 1950 at this point, for how long has been the terrible. But so if you had looked at the clinical trials in March in the world, the tocilizumab trial, so the anti-IL-6 trials, were really targeting the lung. So the criteria were mostly lung severity. While the few emerging from Italy with the anti-IL-1 blockage were not just looking at the lung, but also at the inflammatory markers. And that's what we replicated at Temple. Okay, so despite we were looking at the inflammatory markers, there might be a bias toward not just toward the lung rather than the inflammatory markers, one versus the other. But what I can tell you is that for the preliminary data that I have, we did not see much of a difference in terms of relative success, because fortunately and unfortunately, we do not have a control group. We treated everybody that we needed to treat. Of course. We have a control group for what has been published, and I think we look pretty good in that terms, certainly.
Yeah, I'm not surprised. It does remind me a lot of what I'm used to with systemic JIA. They both work well. They don't work in everybody, but if you took one of them is going to work in 2/3 of the patients, and probably the flip one, and you never know. So it's my gut. So it's interesting that canakinumab was used because, the nice beauty of IL-1 blockade with anakinra is the half-life, and you can just ramp it up. How the safety is so good of increasing it. But we'll see. We need to try.
I did not. I specifically mentioned the anakinra and the tocilizumab because I cannot comment on canakinumab because all the 30 patients that we had were all in clinical trials. So that is not something that we published before Novartis will decide to do so. So that I cannot comment. But for the anakinra and tocilizumab, there is no particular difference. And the other thing that I would add is that we're being very carefully now to present this cohort because, as I mentioned, that we have a very large part of minorities and also a much higher, compared to other cohorts, much higher incidence of diabetes, renal disease, COPD, coronary artery disease is much obesity is much higher in our population, which in a way makes us feel good about what we were able to do because they tend to have worse disease.
Absolutely. Well, that was great. Is there anything you'd like to add that we might have missed or parting?
Yes, I'd like to add something, and two things actually. Sure. The first thing is the fact that I didn't mention enough how inclusive Dr. Criner, the chair of the thoracic medicine surgery, was. I understand from talking to my colleagues in rheumatology around the country that doesn't happen very often. Somehow there isn't much of a communication or an established line of communication that might help both. And I cannot emphasize enough how inclusive he has been and continues to be, and that has been key, very key to our collaboration and great experience, and professional satisfaction of feeling that we belonged to this effort. We as rheumatologists, that I cannot say enough good things about that, frankly. And the other thing, though, is that what I did find very important is that to explain myself why we could have been of help. Certainly, I was given a chance, but if that chance is given or in a way pushed to be given, I think it's also important to be humble and be part of this disease as helpers, because ultimately it is a disease of the lung. And it is an infectious disease. So the rheumatologist, in fact, in several meetings in which we invited speakers to let us know of new approaches that we might have used, I asked questions, and they all wondered what's a rheumatologist doing here. But it makes a lot of sense. We rheumatologists nowadays we need to be also good immunologists. Otherwise, we become less knowledgeable for sure. I mean, all these biologics, they pinpoint immune mechanisms, and it's wonderful. But we need also to demonstrate that that's what we are. We are not just rheumatologists; we are also immunologists. And given that chance, I think many more could collaborate with pulmonology and infectious diseases. But I must say that my trick was to have such an inclusive personality and be ready to help. I mean, I didn't get a day off since March 15.
Yeah, that's terrible. I know it's what happens when you're wanted. See, it's good to be wanted, and then there's the downside. But I think it's fantastic, and I agree with what you said. I was just so impressed when you said there were 200 people. I thought, oh, that's a very big division. I was teasing. I'm just teasing you that you have 150 people, and 100 and 100. No, I knew you had to have everybody, but that's great that the leaders, you need leadership. I agree 100%. You need a good leader, and everybody has to know their role. what are you good at? What do you know? What you don't know? And I just said, they die of lung disease, and that's not what we do. But we do understand, I agree completely, what these molecules are capable of doing.
Yes.
And I think your contribution to getting on the hyper immune system, the HLH-like cytokine storm, is really our expertise. And I agree. So I think it was fantastic.
Thank you.
Temple, and I really wish it happened everywhere, you know. And I want to thank you very much. It was very enlightening for me, and it's nice to see that people talk to each other and and collaborate, because we can't, a disease like this, we can't live in our islands, but we can't do that for anything. So,
absolutely. Thank you, Gabe. Thank you for having me.
And I want to thank you, and I want to encourage everybody who's been listening. Please read the research letter entitled Rheumatologists and Pulmonologists at Temple University Weather the COVID-19 Storm Together, as well as other editorials, articles, and research letters about SARS-CoV-2 infection and COVID-19 disease and its effect implications for rheumatologists, internists, world, and rheumatology practice. And we can see how it certainly affected Temple, the rheumatologists at Temple who don't get time off anymore. So please read the article at www.gu.org/COVID-19. If you have any comments or questions, please message us at Twitter at jroom, or email us at manuscripts@jroom.com. And thank you for joining us, and continue to follow all the regional and national guidelines from your health authorities, and be sure to maintain social distancing to stay safe. And you can see how far myself and Roberto are. So we have a good social distancing. And thanks, Roberto.
Thank you. Thank you, Earl.